Hello, everyone, and welcome to episode number 5 of our Topic of the Week series. It's been a while, so it's good to be back with you. And today we are going to be talking about stroke, and in particular, how to look after our patients after they have had a stroke.
So, NICE defines stroke as a clinical syndrome of presumed vascular origin characterised by rapidly developing signs of focal or global disturbances of cerebral functions, which last longer than 24 hours or lead to death. So, this week on the wards, we've had the usual daily topic cards with the discussion at handover. So, we're going to run through each card for each day as our discussion. So the first card said, what are some of the signs and symptoms of stroke that may be at risk of being missed or presumed as mimics, and how can we identify these and maintain a high level of suspicion?
So, the first thing that jumps to my head is remembering the FAST test and that doesn't cover all stroke symptoms. So, the absence of FAST symptoms does not rule out stroke. So, let's just go through what those are for a start. So, F for face, A for arms, S for speech, and T for time. So, dizziness has been reported, in fact, as the most common symptom of stroke, and that doesn't come into the FAST acronym. So while that is a very helpful tool for the general public to keep in their mind when they're looking out for their relatives, it doesn't cover all the symptoms, does it?
No. So, thinking about our stroke symptoms, we need to go back to thinking about the anatomy and physiology of the brain and its circulation. So, we've got your anterior circulatory system at the front and your posterior, which each feed different regions of the brain, resulting in differences in symptoms. So, thinking more broadly than just the fast symptoms, there's also AVVV. So, that's ataxia, vomiting, vertigo, and visual disturbances. So, because strokes occur in localized areas of the brain, as blood supply to each area is affected, either due to a blockage or reduced blood flow as a result of a bleed, global deficits are really unlikely, as they are generally due to swelling and edema. The SASH strokes pathway starts with completion of a Rosier score.
One of the ways that we can classify strokes is the Bamford stroke classification system. And if you haven't heard of that before, there is a great MDTea episode about it. So please go back and listen to that. We'll put a little link to that just below this video. But in summary, the Bamford stroke classification includes TACS, PACS, LACS, and POCS. And to go into what those are very briefly, TACS is total anterior circulation stroke. PACS is partial anterior circulation stroke. LACS is lacunar syndrome, and POCS is posterior circulation syndrome. So, 4 different types of strokes that fall under the Bamford stroke classification. And if you want to find out more about those, as we said, we won't go into huge depth on that now, but please do go and listen to the episode of our podcast that we will link below.
On day 2, we spoke about secondary prevention of strokes and the importance of this. The number needed to treat for patients with a history of stroke with antihypertensives to prevent one stroke is 11, and between 50 to 120 with statins, but this does depend on what timescale of stroke prevention you're looking at.
Next up, we thought about the impact of stroke on patients that might be more subtle and more difficult to spot. For instance, half of all patients reported fatigue following stroke, and 43% felt they had not received the help that they needed to address this. One of the other things that can frequently happen as a result of stroke is memory deficit, and strokes double a person's risk of dementia, as well as increasing their risk of constipation and a loss of bowel and bladder control.
And thinking about the classical symptoms of stroke, such as limb weakness and speech problems, these have a huge impact on patients, resulting in a loss of mobility, a loss of independence, and a lack of confidence. Speech problems like aphasia can impact patients' mood, well-being, and relationships, and also social opportunities. On day 4, we talked about antihypertensives and looking at deprescribing for some patients depending on their levels of risk. For a bit more information on that, go back to our multimorbidity episode of video or listen to the MDTea podcast, 11.4 Day in the Life of a Pharmacist, where in both episodes we talk about the start-stop criteria.
And on our last day, we spoke about the long-term follow-up for patients with a history of stroke. And this is so important because stroke can result in minimal disability in some people and quite severe disability in others. And the rehab is such an important part of the process. Did you know, for example, that 6 months post-stroke, there is no longer funding for input for stroke rehab, and most services after 6 months are provided by the tertiary sector? This means that the ongoing care and input varies significantly between regions based on availability and accessibility of services for patients following their strokes. The Charity Stroke Association are one of the largest UK charities supporting patients after stroke. They have some really good resources for patients, carers, and families on their website, and they also have a helpline that's open on weekdays.
We also talked about the impact of stroke on discharge needs. The nature of stroke means that many patients require follow up care and are unlikely to recover fully. 1 in 12 patients who previously lived at home now require care in residential care homes following a stroke. So it's really important to remember that that's a really difficult change for them and their families to adjust to. Sadly, research has also shown us that a quarter of patients who are discharged to residential care facilities are unable to access effective ongoing rehabilitation, such as community physiotherapy. And research is ongoing about the reasons for this.
So, to summarise, when thinking about a stroke, strokes have a range of symptoms. Yes, there are some that are more common than others in terms of facial asymmetry and limb weakness, but we can see lots of other less common or maybe less well known symptoms. And we should also be aware of stroke mimics. So that could be things like hypoglycemia. It could be things like cognitive change as someone gets older, maybe the beginning of a dementia process. And we should ensure that we thoroughly assess for stroke by being aware of assessing all these extra subtle signs, things like ataxia, visual disturbances, even vomiting, vertigo, and dizziness. It's important not to miss a stroke because, as I'm sure you've all heard before, time equals brain. So if somebody has had a stroke, we want to be able to investigate and treat that as soon as we possibly can. So, yeah, be aware of the subtle things that may suggest somebody has had a stroke.
Next up, secondary prevention is really important post stroke and should be started as early as possible, ideally within the first 24 to 48 hours. Thirdly, stroke can leave patients with less obvious ongoing issues like fatigue, bowel and bladder movements, constipation, and low mood. So it should be really important that we ask the questions to identify these for patients.
Finally, we need to remember the impact of stroke on patients and the people around them because one statistic that's really worth keeping in mind is that people who previously were independent and then have a stroke, 1 in 12 of those people will then need new residential care post stroke. So it's so important to be empathetic to our patients and all the changes that they're experiencing because this could be new and frightening for them. And we need to try and take a walk in their shoes and appreciate what they're going through.
And that's our Stroke Week content done for you. Come back next time where we'll be chatting all about dementia.